Hey Fix listeners, I want to take a minute to give you all an update on our DPO, Smile Now Dental Group. In case you haven't heard, we've been opening up locations all across the country for doctors just like yourselves. We started several offices this year to show proof of concept, and it's been off to the races ever since. So if you're looking for an equitable partnership opportunity where you can have a profitable business that supports you doing full arch, I'd love to hear from you. We're looking to add several locations in the next year and want to offer the training and support necessary to make one of those yours. If you'd like to learn more, you can go ahead and hit me up on Instagram at Dr. Tyler J. Tolbert, or shoot me an email at tyler@smilenowdentalgroup.com and say hey. Now, without further ado, let's get back to the show. My name is Dr. Tyler Tolbert.
And I'm Dr. Soren Poppy.
And you're listening to the Fix Podcast,
your source for all things implant dentistry.
Absolutely. So I have a few miscellaneous questions as well, just kind of based off of, what your experience is and all the different things that you can, kind of bring to implant dentistry with your extensive background. So you mentioned, you had done some research on postmenopausal women and issues with bone formation and things like that. And so I am kind of curious if you have any opinions on, like the AOMS position paper on bisphosphonate medication and related osteonecrosis of the jaws and things like that. What is kind of your position and what do you tell your residents as far as patients that are taking bisphosphonates, oral or IV, different kinds of treatments that could be used to help prevent osteonecrosis in regards to implant treatment?
Okay. That's a great question. It's something I'm very passionate about.
Oh, good.
It's something that I lecture a great deal on and put a big part of my life into looking at it. I think the Women's Health Initiative of 2001 through 2003 was a misinterpreted study. That study was based on, it was sponsored by Wyeth Laboratories, who had a medication on the market called Premarin and another medication called Prem-Pro. Premarin was a conjugated equine estrogen, which came from the urine of pregnant mare horses. That was the estrogen we're going to go ahead and give these women, but it was being done. Then they had another component of the drug, and they envisioned that every woman in the world would be taking these two drugs, one of these two drugs, either Premarin, conjugated equine estrogen, or Prem-Pro, which was a conjugated equine estrogen plus a synthetic progesterone called medroxyprogesterone. Okay, and they just thought this is going to be the best study in the whole wide world. We're going to put all these women in it. The study was not well defined, but because they wanted to just get so many massive numbers, we had women in there that were smoking, and that was a real confounding factor for blood clots and for cancer, and et cetera, et cetera.
Of course.
But they had them in there. And the pharmacologist, we knew that of all the sex hormones that can cause breast cancer, the number one is synthetic medroxyprogesterone. Okay, We knew that before that was even there. I'm sure the pharmacologists at Wyeth were probably screaming, but you have the money managers of these pharmaceutical companies that are saying, "Wait a minute, we've got to sell drugs. Somebody's got to pay all these salaries. We've got tremendous overhead." And what's the instance of it? And of course, as scientists, we're always accused of over-exaggerating everything. And the business people are always saying, it's not a big deal. You're over-exaggerating. And the pharmacologists are saying, wait a minute, you're under-exaggerating. So there's always conflict at pharmaceutical companies between the scientists and the money people. Mm-hmm. And I realize it has to be a balance. It's not one right and wrong. But anyway, that study, they got into it roughly 2 years, and they found that the group getting the Prem-Pro had a much higher incidence of breast cancer than did general society, the rest of the women that weren't taking anything, or the group just taking Premarin. Okay? Mm-hmm. So the Prem-Pro study was stopped abruptly, quickly. It should have been. It was, and they did the right thing in stopping it. It's just that the press and unfortunately physicians, they just kind of fell and followed in line with what everybody was saying because there were attorneys, and they were saying that women should not take estrogen because estrogen causes breast cancer. And pharmacologically, that is not a true statement. If you have an ER-positive breast cancer cell, estrogen taking it will induce that cancer to grow. Okay.
Sure.
So I could go on for about 4 hours just on that topic, but you asked about bisphosphonates. So since everybody went off all their estrogen and all their estrogen with progesterone, they went off of it. Everything was pretty good for about 4 or 5 years, because when you go off estrogen, whether it be endogenous or exogenous estrogen, you don't get a major change in your bone structure for 5 years. Mm-hmm. So things remained pretty good till about 2007, 2008, thereabouts. Don't quote me on those exact dates, but it's roughly 5 years after everybody started going off of it. Definitely by 2010, everybody was now moving into something for osteopenia, osteoporosis treatment or prevention. And that was bisphosphonates. So let's go ahead and start giving them bisphosphonates. So everybody starts taking bisphosphonates. Now, the thing of it is, all postmenopausal women pretty much universally start taking it. And there's some other things about that just besides dental, but I'll limit the discussion to dental for right now.
Sure.
That these drugs, what they do is they inhibit bone remodeling. That's what they do. They inhibit bone remodeling, and they do it by preventing bone resorption. Mm-hmm. So when you want to remodel bone, you've gone in there and you've done a bone graft, you've decorticated that bone and whatnot, and you put that bone graft in there and you want it to turn over, the osteoclasts get activated. The osteoclasts, they will break down the bone in the area for you. And when they do that, they free up BMPs, bone morphogenetic proteins. Those BMPs now, they go over to mesenchymal stem cells that are in the area, induce them to proliferate, so they go from X to 10X, or X to the 10th power, okay? They just proliferate them tremendously. Those same BMPs, there's lots of different ones there, but those same BMPs will then induce those mesenchymal stem cells that have been proliferated to differentiate into osteoblasts. Mm-hmm. And then to top it off, they'll go and land on receptors, it's all pharmacology, land on receptors to induce those osteoblasts to lay down new bone mineral matrix. So now your bone graft turns over, your socket graft, your implant osseointegrates, etc. Right. And so you need bone remodeling to make bone. And when you take a bisphosphonate or monoclonal antibody, you are preventing the osteoclasts from freeing up the BMPs from the bone mineral matrix.
Yeah, from the very start of it.
So you've turned off the switch that enables bone remodeling.
Yeah.
In other words, if I have an old house and I want to build a brand new house on that same property, you got to tear the old house down.
Yeah.
If you don't tear bone down, you can't make bone. Well, now bisphosphonates. We have an oral form of the drug, okay, like Fosmex, lindronate, which is 10 to 100 times more potent than the original bisphosphonates, which weren't very effective at all. So we came out with all these oral ones, the pharmaceutical industry, that Beniva, Fosmex, et cetera, et cetera. The only thing is it's very difficult for us to predict where you get ONJ with those drugs, because if you take a bisphosphonate orally and you take it on an empty stomach, you get 3% absorption. 27% goes out in the fecal material. Okay. But if you take it, and once you get it absorbed, of that 3% that gets absorbed, we'll say you took 70 milligrams, so you got 2.1 milligrams absorbed. 10% of it goes to sites of active bone turnover. Well, do you have active bone turnover in your jaws? If you have no periodontal disease, a stable occlusion, no bleeding on probing, you've got very little bone turnover going in the jaws. You've got very little bit of that drug going to the jawbone. So this jawbone is doing whatever it normally does because you've got very little drug.
Yeah.
But the spine, the hip, the ankle, those have a lot of bone turnover on it. The subtrochanter and the femur, they've got a lot of bone turnover. Or if you have periodontal disease or an unbalanced occlusion, now you've got a lot of bone turnover. So then that 3% goes there. Am I getting Is this too much science? Is this
No,
one?
this
this
is
is great.
We're tracking.
This is really good.
Okay.
You're dumbing
My
it
wife-
down.
This is the stuff. This is the stuff we want to hear.
This is good.
My wife
This is
says,
good.
you got to lighten this up, Jim.
No, this is
No. This is great.
I know you can make it way more
Okay,
complex.
so- Now, when it starts to go to the bone, before you ever took the drug, you had no concentration of it in the jaw bones at all. And I'm going to say you're missing 19, 18's tilted, 20's tilted, 14's dropped down. We got bone turnover going over here.
Yeah.
Over here, man, you brush really good. You floss this side really good. You never lost a tooth. It's stable. Very little bone turnover. Lots of bone turnover going on that left side.
Mm-hmm.
So when you first took it, you had no concentration. You took one pill, then you ended up with a 10 to the minus 500 millionth molar concentration. Well, at that low concentration, not only did you inhibit osteoclasts from breaking the bone down, but get this, and it takes about a year, it worked for the first year, you actually stimulate the osteoblasts to lay down new bone. It's a quirk of pharmacology, but it's well known. So for the first year, you start to make better bone. This is pretty good. But then the more you take it, it stays in the bone. It doesn't come out for years. You build up a concentration. When you get to about a 10 to the minus 15th molar concentration, now it's toxic to the osteoclast, the osteoblast, the angioblast, the osteocytes. Every living cell in the bone dies.
Yeah.
Now you can't break bone down and you can't make bone. Because you didn't break bone down, you can't make bone. Estrogen, by the way, it stimulated the osteoblasts to directly lay down bone. But we took you off estrogen. We said, you're not allowed to take estrogen anymore. And I don't want anybody to get breast cancer. We needed to be thinking about genetic testing, familiar history, breast cancer, etc. But, so now, after about a year and a half or 2 years of taking this drug, if you had bone turnover, you got a toxic element there. So if somebody goes in and takes out 18, you can't turn that bone over. You got no blood supply there. You can't heal that bone. And that whole thing there's about a 2-hour explanation that goes to that. So I'm going to just say, just take that as that's what happens there. That happens. Now over here, somebody else takes out number 5 because they broke down a hard nut and broke it off. Well, that heals just fine. But over here it didn't because the drug was here, it wasn't here. Now, to make it worse though, if you take a bisphosphonate with food in the stomach, because the drug is very irritating, it's very acidic. And when you take it, you have to remain upright. You have to drink 8 ounces of water with it. You can't lay down for an hour or 2 because it will roll back up the esophagus and cause esophageal varices for you. It can cause esophageal cancer for you. It's a strong acid. So what do people do? They say, Dr. Jim, it bothers. How do you take your drug? Well, I take it with some crackers or some toast. If you take it with food in your stomach, you get 0 absorption. You're never going to have a problem with O&J because they never absorbed any of the drug. They never got it to the bone where it could cause that. They never interfered with the bone. Hey, how's your osteoporosis doing? Oh, the doc says it's not doing good at all. Well, that's because you haven't been taking a drug. You've been taking a drug, but it never got absorbed.
I see.
Where IV, though, when you give the drug IV, you guys know, when you give a drug IV, your blood level's 100%.
Yeah.
And the IV forms of the drug are 10 to 100 times more potent than the Fosamax was. So now we gave you a much more potent drug. You got 100% blood level. We were giving it to you for cancer treatment. We gave you that IV treatment probably once every month or every 3 weeks or every 2 weeks. A much more potent drug at a higher concentration, higher dose. Well, now those are the people that get a lot of O&J. Now, the other thing is when they, and if I get too excited, you want me to settle down, just say settle down.
No,
This is awesome.
excellent.
Yeah, I really, it's funny. I appreciate that, for a long time, I've understood the whole, 2 years on orals is kind of a cutoff or whatever. But it's just like, it's very immaterial. It's like, okay, 2 years. That's just a reference in my mind. You're really helping us understand, where that actually comes from and the dynamics of how that drug was being taken, if it was being taken properly, and what the local oral environment was like during that time and how it might be different on one side versus the other. And I had never heard anyone explain that. So I appreciate it.
And in our research company, we did modeling on bisphosphonates, and we came up with 70 milligrams a week, typical. If you're in an area with bone turnover, so that's somebody that's got some periodontal disease, not a balanced occlusion, not 28 beautiful pearly white teeth. We're talking somebody, the typical 72-year-old lady, that's got some issues there and wearing a partial and et cetera. That those. We found in our modeling it would take 2.5 years to get to a 10 to the minus 15th molar concentration. Now, a lot of assumptions were made in that. I got to admit, a lot of assumptions were made.
Yeah.
But when we look at these studies and we say, who gets it? Well, the numerator in these studies is who got ONJ. Well, we had 1,000 cases of ONJ, okay? We had 1,000 cases of ONJ. People got something done, something happened, and they got ONJ. And there had to be an inciting event. Somebody had to do surgery. Somebody had to take a tooth out. You had to cut the gingival tissue with a fork or, a gash from, crispy foods or something of that nature. You had to get that bone exposed. You had ONJ when you were covered with all the gingiva. It's when somebody opened it up. Now it couldn't heal because there was no blood supply in the bone to help that soft tissue heal over. So it just opened and opened and opened and opened and greater and greater and greater. And then you got actinomyces down in that bone. Yeah. And now you got a bone infection, an osteomyelitis. Mm-hmm. But guess what? You can't cure it because you got no way of getting the antibiotic into the bone. There's no because there's no blood supply.
It has to be debrided, yeah. Okay.
So, that's where it was. So if somebody, the numerators, everybody who got it. So who do we put in the denominator? Well, they put in the denominator everybody who took the drug. Well, you know what? I don't know. We had 10 million people, 10 million women in the United States taking the drug. There were 1,000 people that got ONJ. You divide it by 10 million who took the drug. Now, that is a 0.0001% chance of it. You go like, well, that's not very many people. What are we even worrying about? For those that get it, too bad, too sad. That's not the attitude we should be taking. But that denominator should have been who had an inciting event, who got a tooth out. That's who goes in the denominator.
I see.
So maybe it's 1,000 people got ONJ, but only 10,000 people got a tooth out. That's who should be in the denominator.
Yeah, now you got
not
more
the
like
other
1,900,000
people.
Yeah.
You follow what I'm saying?
Yeah, I do.
So it was like, whoa. So in Australia, they did some studies, and they showed that the instance of somebody having a tooth out and going ahead and they'd been taking Fosamax, and they had to be taking it for over 2.5 years, et cetera. All these criteria were met for it. The instance of ONJ was substantially higher. It went anywhere from 0.34% to, depending on what the dose was, like in Paget's disease, you get a higher dose and whatnot. Those individuals, they had upwards of a 34% incidence of ONJ.
Wow.
So the dose of the drug, the duration of the drug, the route of the administration of the drug, what was the health of the tissues, was there an inciting event or not?
Yeah.
And now that people have been on these drugs for multiple years, 8, 10, 15 years, it may have taken 15 years to get it to where it was toxic, but now they just have any little thing happen to their gingival tissue, they cut it with a toothbrush, and then bingo, all of a sudden they've got ONJ.
I see. Okay.
They had ONJ before, it's just they didn't know they had it.
It wasn't exposed.
And you look at the x-ray and you go, hey, your bone looks pretty good there. Well, it's not turning over. It's stagnant. It's not living. It's dead bone. And dead bone You can't take a tooth out of dead bone and get it heal. You can't get the gingival tissue coapted over it and expect it to heal. It's just not going to happen. Now, when it's IV, then it is much, much more predictable. Those individuals that take the IV form of the drug for cancer treatment, a higher dose, more frequently, they get a tooth out. They found that if you take a tooth out in somebody that's gotten 3 doses every 2 weeks at the doses to treat a metastasis to the bone or prevention metastasis to the bone, after 3 doses, they stood about a 60% chance of getting ONJ. Quick.
Wow.
That's huge.
Yeah. So it makes a big difference as to the dose, the duration, the route of administration of the drug. Now, there is a study that showed that you could reduce the incidence of ONJ 74% in those people that met the criteria. They took it right. They had all the things. So we're taking the real patient, or they were under cancer treatment, okay, prevent metastasis IV with it there. Frequently higher doses and whatnot, and stronger forms of drugs. This was also true with monoclonal antibodies, by the way, which are very similar, different but similar to bisphosphonates. 74% reduction if you could eliminate all bleeding on probing before you ever did your surgery. Get rid of all inflammation in the oral cavity, reduce your levels of IL-6, interleukin-6. If you can reduce that appreciably, and that can be just demonstrated visually, is when you take the periodontal probe and you probe 6 readings per tooth. Do you have any bleeding? I got no bleeding. You know what? I stand a 74% chance of taking your tooth out, suturing you up. I might do a few things in there to help me heal, but I'm not going to get ONJ most likely, even though you were on this high dose IV form of the drug, because I had rid of the inflammation. Now the soft tissue itself can tend to heal itself, whether there was a blood supply coming from that periosteum or not, or from that bone through that periosteum. So, and we did a study in our group with it, and we reduced it 73%.
Wow.
The literature said 74. Our study showed 73% reduction with it. So it's something that we treated a lot because our clinic, we were associated with 2 cancer clinics, and they would send us these patients that were getting either experimental monoclonal antibodies because one had a huge clinical trial going on with NIH that we needed to find out what they were on. So they would break the code for us on patients, and we would do their surgeries. But it's a topic I'm very passionate about.
Yeah, no, absolutely. So I want to make sure I don't butcher your conclusions there. So it sounds like that even in patients who had IV exposure to bisphosphonates or monoclonal antibodies, if you could just reduce the inflammation in the tissues prior to the exciting event, you could massively reduce the incidence of osteonecrosis.
Right. And that meant good string flossing, electric toothbrush twice a day for 2 minutes each time, or at least a minute in the morning and 2 minutes at night, and then water irrigation. Okay. And we put all those patients in our clinic on those. We gave them and I know we're supposed to tell commercial product, but it was the Water Pick Sonic, the one that's got the brush and the bar, and I'm telling you what, we did surgery on those patients every week, and we had very, very few complications. Now, awesome. I also irrigated the bone tremendously with a lot of saline. Yeah. I would try, and if I had areas where it was obviously necrotic bone, I would remove that bone before I would close them. I got primary closure. I would use Buffy Coat PRP on collagen down, and then PRF under the suture lines. I would use horizontal mattress sutures to keep the tension away from the suture line, then just at the suture line doing interrupted or continuous, and that helped a lot. Now, I did order 2 sets of lab tests, and it was not to predict ONJ. And the ADA is 100% correct. You cannot predict ONJ. I think your biggest predictor, quite honestly, is inflammation. And then looking at the radiographs, if the bone has a sclerotic appearance, that tells you there's not much of a blood supply. If it looks sclerotic, then that really upped the game. And I always got in signed consent forms, and I'll share that with you guys. And you can share with your readers if you want in signed form consent for bisphosphonates and monoclonal antibodies. But I wanted to be able to predict whether you were going to make bone or not. So I ordered 2 lab tests. And the one was a serum NTX. That's a serum Nancy Thomas Xavier. NTX are the initials. And that tells me how well the osteoclasts are working. And I wanted the patient to be in the range of a 40 to 44-year-old premenopausal woman. And that, because those women, they are breaking bone down. They're remodeling bone. They're breaking bone down, and they're going to make bone because they broke the bone down. So I want an NTX, and I don't care whether you're 90 years old, it is possible for your NTX to be in that range. Then I ordered a serum BSAP, that's bone-specific alkaline phosphatase, serum BSAP, and I wanted that in the range of a 34 to 44-year-old premenopausal female. And that told me whether the osteoblasts were working. Could you build the bone? So before I went in and did this all on X, or this bone graft, or even just a single implant, maybe should we be doing a fixed bridge for you? If we really want to know, I want to know whether you can heal that bone or not, whether you can make bone. Can you osseointegrate an implant, and can you do that? And I realized Bob Marks, he used a urine CTX, because when he came out with it, that's what there was being used here in the United States. The serum NTX started being used in Japan. Japan is way ahead of the research on postmenopausal women, because Asian women have a much higher incidence of osteopenia, osteoporosis than does the rest of the world. So they're way ahead in their research. Now a serum CTX, I don't know the ranges on that like I do the serum NTX. So I personally have stayed with the serum serum NTX, and didn't go over to the newer serum CTX. But that just gave me the confidence. Does this look like this has a chance of working? Because now they're universal lab tests. They weren't specific for the jaws. But if the numbers were bad, you know what? You might not make bone. If the numbers were good, you might make bone. Mm-hmm. And so what I did is I got you all cleaned up. Good prophy, good scaling, root planing. I want no bleeding on probing. You're doing good daily oral hygiene at home. I would get these tests. If the tests were good, I said, I want you to stop taking the bisphosphonate or the monoclonal antibody with the physician's permission for 16 weeks. Because I want to put my implant in, or my bone graft, and I want it to turn over. Okay, so we're not going to take any drug for 16 weeks if the numbers were good. If the numbers are bad, I want you to take a 6-week holiday, okay? And then we're going to repeat the tests. And if the numbers are good, we're going to go ahead and do your surgery. You're still signing a consent form. And the reason being is you didn't kill every osteoclast and osteoblast induced necrosis, every one of them in the body. No, you still have some that are working. It's just that now you haven't been on the drug for 6 weeks, okay? Or if you want to be a bit more conservative, you can go 3 months, okay? And I think 3 months is probably a better number than 6 weeks. So wait 3 months, repeat the tests. If the numbers are good, go ahead and do your surgery, but don't start the drug up for another 16 weeks. Does that make sense?
Yeah, it does.
Okay.
It does.
Yeah, it does. Okay, so I got a couple questions. First, is this just for patients taking IV bisphosphonates or oral and oral?
I had everybody that took a bisphosphonate or monoclonal antibody. That's what they did. If they'd been on it for 2 years.
Okay. So good lab tests, 16-week holiday, then you place your implant. Mm-hmm. Can they jump back on it right away?
Nope. Once I do my surgery, I want to give them another 16 weeks.
Holidays after the procedure.
So you place once you place the implant, wait 16 weeks. Once you've got the implant in and it's osseointegrated, now they can go back in the drug.
Got it.
Hey guys, I just want to take a beat to talk about one of our sponsors, SIN 360, specifically their full arch digital workflow. Here at the Fix Podcast, we've been using SIN for about 2 years, and one of our favorite integrations from this workflow is the Micron Mapper. Photogrammetry is an absolutely pivotal technology that has changed the way full arch is being done. It's allowing us to capture implant scans in under 5 seconds with micron level accuracy that's beating any type of scannable verification jig or analog verification jig, what have you, and it's able to do it in under 5 seconds. And guys, SIN 360 is absolutely giving this thing away right now for $699 a month for 39 months with 0% financing. Think about that, $699 per month. That's about the cost of an analog conversion or fabricating an analog verification jig, or maybe even just a scannable verification jig. So I highly, highly, highly recommend you try this out. It's one of the most pivotal investments that you can make in a full arch digitally capable practice. To learn more, visit sin360.us/thefixpodcast and get yourself a Micron Mapper today.
Got it. Okay, so if good tests, and we'll try to put these numbers in the show notes so people can look. But if they have good numbers, you'll place the implant right away and then have them take a drug holiday for 16 weeks after the fact.
After integration.
Right.
If the numbers are bad, 6 week, or you said 6 week or 3 month if you want to be
Go
conservative.
with 3 months. Go with
Yeah,
3 months.
retest.
Retest. If numbers look good, place the implant, wait another 16 weeks.
Yeah.
Does it matter how long they've been taking the oral bisphosphonates?
Yeah. I mean, if they took it ideally, and it was 70 milligrams a week, which that's what everybody took in Fosmex. Osteopenia dose was 35 milligrams a week. Osteoporosis dose was 70, but everybody got 70 milligrams. Even when you had a diagnosis of osteopenia, everybody got 70, seemingly so. I think in all my years, I only saw 2 or 3 people on 35, but over half those people were just osteopenia. But if it's 70 milligrams every week, and they took it just as they were supposed to on an empty stomach, there is a report of as early as 18 weeks somebody getting ONJ. But that could be just an outlier.
Right.
That could be just an outlier. They may have had other morbidities. Maybe they smoked as well.
Yeah.
Maybe they were taking long-term steroids, because there are other comorbidities besides just having that surgery. But traditionally, we didn't see it in under 2 years. Now, if you didn't take it right, you might have taken the drug for 10 years.
Yeah.
It wouldn't matter. Right. Yeah.
Right. You weren't at risk.
Yeah.
So it was how did you take the drug, the duration, the state of the oral cavity, amount of inflammation, so there's just so many compounding factors. It's very difficult. I agree personally with 90% of everything that was said in that ADA paper, in the AOMS paper, I should say, the AOMS paper. I agree with 90% of it there. But they did not have one pharmacologist on there.
Yeah.
And I think they should.
And that's crucial.
It's a pharmacology question. It's not
It
an oral
is, and there's
surgery
nuances.
question.
Yeah, for
It's
sure.
a pharmacology.
So you have placed implants in patients that have been on IV bisphosphonates, on oral bisphosphonates, as long as the protocols are followed properly. The test came back well, and overall, you said
Reduced inflammation.
as long. And how long would you have them? Like you talked about the brushing, water pick, flossing. How long typically would it take your patients to get to a point where no bleeding on probing?
They would have that in 3 months. So between
many
of my implant patients, I'm very discriminating about oral hygiene with dental implants, because I came up in the 80s when nobody understood the importance of it, and then we had so much peri-implantitis. That I learned from it the hard way, not by reading papers, but by experiencing it. So it was usually within 3 months, between 3 month prophylaxis. You come in, you get your consult, et cetera. This is what you need to do. We need to get this all cleaned up. You're going to come in, you're going to get your teeth all cleaned up here, scaling, root planing, whatever we're going to do with that. If there was periodontal disease, we got the periodontal disease eradicated the best we could before we ever did it. And even if I was going to take out all their teeth, and when I was doing this in the 90s, we weren't doing all on X's. We were doing FP1s or overdentures or things of that nature. That we still followed that protocol, and that helped us tremendously by getting no smoking. We didn't want any bleeding and probing. But within 3 months, just about everybody could be to the point where we did not have any bleeding and probing. And I thought that was a huge factor for us.
And
Yeah.
I'm curious too, do you sponsor any other like adjunctive therapies prior to the procedure? So obviously, people talk about hyperbaric dives. Some people are fans of administering pentoxifylline and vitamin E for some time prior to the procedure and after the procedure. Do you feel one way or another about those? Could they hurt? Or do they do any good?
The literature is not. I try to do everything in my life based on what does the literature say, and I realize that the literature is flawed and the literature is incomplete.
Sure.
Okay, so just know that I'm very much aware of that. I think that it is very important for these patients to go on vitamin D.
Yeah.
Ahead of time, and I like them to be on that for at least a month, if not 2 months. And I like it best when we have a vitamin D levels on those patients from their lab tests and whatnot, because that can help us prescribe most accurately. But if for whatever reason we don't have that, then I put them on vitamin D3, 5,000 units a day, 1 month pre-surgery. And then I keep them on vitamin D3, 5,000. It's vitamin D3, 5,000 units 1 month prior to surgery, then vitamin D3, 5,000 units daily for 2 months afterwards. And it is a lipid-soluble vitamin D3 that you can get toxicity, but it would take you a long time at 5,000 units a day to get the toxicity. So if you're in the Northeast, or if you're north of the Mason-Dixon line, even if you're north central or Northwest United States, where you get very little sunshine, and even though the people that are in Phoenix, Arizona, they're all wearing long sleeves and sunscreen now, they're not getting much vitamin D.
Right.
Technically, we should have the blood levels, but if we don't, 5,000 units a day for that criteria, a month ahead of time, 2 months afterwards, you're not going to get in trouble. Then go to 2,000 units a day, you will not get in trouble with vitamin D toxicity.
Okay.
Could you go vitamin D 5,000 units longer than that? Yeah, you could. But without a lab test, we don't know that definitively. I'm just saying those numbers, 30 days before, 60 days after, and then 2,000 units a day thereafter, particularly in the populations beyond the age of 70, most of them have some vitamin D deficiencies anyway.
Right.
So
I've got that was really good.
Awesome.
And our listeners will really appreciate that. We don't have a ton of time left, but I'd love like a quick recap on your thoughts for patients who like radiation levels. My understanding is typically under 60 grays, you're a lot, in a much better place for implant placement. So I'm curious on your thoughts on that. And then I'm curious your thoughts on A1C levels and where you're comfortable placing implants with patients, if you have time to answer those.
Yeah, 55 to 60 grays should be the cutoff. Okay, that should be the cutoff. But the more important thing is that you get with the oncologist and you look at the mapping. Where was the radiation given? What was shielded and what was not shielded? And they are very good at shielding. So if that radiation treatment is probably in the last 8 years, 10 years, they probably had excellent shielding techniques. Even if it was head and neck radiation, they probably had excellent shielding techniques. And if that bone was shielded, then you probably don't have much of an issue whatsoever. But you've got to talk with that oncologist. They are very willing to talk with you. Many physicians, they get very busy and they have bigger fish to fry than talking to the dentist about their patient. And so many times talking to the nurse practitioner or their head nurse in the office and whatnot, they're more relatable many times just because they don't have as many things going on inside their head that maybe that head doctor does. But I will say the one exception to that is every time that I have had to talk to an oncologist, and when we worked with the cancer clinics, we talked with them all the time. Those individuals, they were really, they knew the consequences of oral surgery in somebody with radiation. And they didn't want those patients to have a problem. And so I found if there's one group of physicians that'll give you everything, they'll lay it all out there, it is the oncologist,
Okay.
the radiologist who does that treatment for them. So one, make sure you do a consult, make sure you get the number of grays, make sure you get the mapping. And again, make sure there's no inflammation in the mouth, because we believe, we don't have the literature to support it, but we believe we would probably have something similar with that lack of inflammation, allowing us to have better healing force there. Then, depending on what it is, then we may have to be talking about hyperbaric oxygen and things of that nature.
I have the reason I was asking in particular is I try to stay away from bisphosphonate patients and radiation patients just to be conservative, right? But I did have one patient that I did an upper lower all on 6 on probably a month and a half ago, and he had some neck radiation. But I met with the oncologist. We went over all the mapping, and I ensured that he was under 55 grays in all areas that I was placing implants. And he had also done full hyperbaric oxygen therapy. Okay. So he's in the healing process right now, and everything seems like it's healing great. But it's always that thing I'm thinking about. I'm always like, until he's fully healed, I'm always just going to be like, all right, hopefully everything goes okay. Yeah. But that's great to hear from you. What about your 8? Oh, go ahead.
You might let those implants integrate just a little bit longer, and then do your ISQs on there to see what kind of readings they've got before you do load them. Because the implants will go in that bone, and I think you've done everything just exactly right. You did everything right. You talked to the oncologist there, and the hyperbaric oxygen. You did all those things just exactly right. But if the bone is not turning over quickly or at all for you, when they first go in, yeah, they can be nice and stable, but then do they truly osteointegrate?
Right.
But you did everything absolutely right as far as I'm concerned from my vantage point here. HA1Cs. When I lecture, I try to keep everybody up from having trouble. I don't want you to have trouble. And the literature strongly supports that an HA1C above 7, you probably shouldn't be doing elective surgery on them. Now, that's not to say that a 7.1, a 7.2, you can't squeak by, and where did they start out? Did they start out at 14 and they've been working for 9 months with their endocrinologist and the best they can get them is 7.2? Well, okay, that's a considerable amount of improvement. Well, 7.2 is not 7.0, so Jim, you mean the guy, So what I'm saying is, we have to make everything realistic in this world too. But if you want to play it conservative, 7.0, you never do an elective surgery above that. If you said, I'm willing to stretch, I know the patient, they're going to do best hygiene that they can possibly do. I'm going to be careful. We're going to get them in every 3 months. They're going to do everything they can possibly do. All right. And you're not a litigious patient, I'll go to 7.5 with you. Okay.
Yeah. Okay.
I think anybody that does anything beyond 8 is, why don't you just go out and take money and burn it in the streets? Because at least you see a nice fire. Otherwise, all you're going to do is see those implants again.
Yeah. And
you're going to do them again and again and again, and that's going to cost you money. So just burn the money the first time. You'll be just further, you'll save yourself time.
Save yourself time.
Okay? So nothing above an 8. If it is between, if it's below 7, great. And sometime we'll talk about maybe steroids and things of that nature, because there's steroid doses in what we do. But if it's below 7, yeah, I go ahead and I do the implants, grafting, whatever has to be done there with it.
Great.
Yeah. Are there any other? I mean, those are kind of the 3 big ones that I feel like people talk about the most, right? Uncontrolled diabetes, head and neck radiation, bisphosphonates. Is there anything else that you think that our listeners should be really aware of as like an absolute contraindication?
And like protonics and antidepressants as well to some degree, not an absolute contraindication, but people are talking about.
Yeah, those are less. If it's an SSRI,
right,
I suggest you let those implants integrate for longer, and maybe when you do load them, you load them with an acrylic-based tooth. an acrylic occlusal surface, I should say, that's going to wear form. Because I wanted to wear, realizing full well you're going to have to replace them more frequently than you are maybe zirconia or something of that nature. But they need a shock absorber because that bone, those drugs, they interfere with bone remodeling. They put them in a negative remodeling state where they're going to break bone down more than they're going to build the bone up from there with an SSRI. Of the 25 top, the 25 top drugs prescribed in the United States in 2022. That's the latest data I have. Is 22. I don't have 23 data and 24 data yet. That comes out from the pharmaceutical industry. But the top 25 drugs prescribed in 2022, every single one of them had an effect on oral health or healing of oral surgical procedures. So some of them were positive, some of them were negative. But I think the biggest factor is, I could say, from what I've gleaned from the literature in just about everything, and confounding factors, 44 years of clinical experience, is you want to make sure they got good oral hygiene. Yeah. I think that Waterpik Sonic, every single patient got implants in my practice, they got a Waterpik Sonic. They got one implant, you got a Waterpik Sonic.
Great.
I was retired for 14 months. One of my patients, whom I was friends with, and he had my cell number. He texted me. He says, "Jim, I just came back from the people that took over my practice." He said, "And I had a perfect checkup. And I got to tell you, Jim, I want to thank you for all the things you ever did for me." And that included implants, restorative, et cetera, et cetera. He said, "The best thing you ever did for me, though, was give me that electric toothbrush that puts the water out."
Oh, that's great.
And, I thought that was unsolicited. He just called it out. In fact, he called me at Christmas time, and he said, "All my grandkids for Christmas got a Sonic, a Waterpik Sonic."
That's good.
He said, "If I would have had one when I was a kid, I wouldn't have needed all that work from you."
Hell, I don't have a Waterpik Sonic, and I might be getting one.
I know. I can see him searching Amazon right now.
How much are these things? Like, we give all of our patients Waterpiks, but not Waterpik Sonic. So I'll definitely have to look into that. And I appreciate the advice.
Yeah.
Hey, I've enjoyed my time with you guys.
For
Hopefully,
sure.
I didn't wear out my welcome.
No.
No, not at all. Before you go, though, please let everyone know what the best way to find the residency program, to get more info on the residency program, to maybe reach out if they want more info. That'd be really helpful.
Okay. You want to Google Jacksonville University Comprehensive Oral Implantology Program. So again, Jacksonville University Comprehensive Oral Implantology Program. If it's okay with you guys, I'll give my phone number.
Please.
Yeah.
And I'm going to just ask that you text me, because I got a spam blocker and it's not in my phone. It doesn't ring. So I tried to call you. My phone number, text me, send me your card, and then I'll put your card in there and put in there that you want information on Jacksonville University program. And that number is 803-415-4838. Again, 803-415-4838. And for those of you that have a great deal of clinical experience, you are oral surgeons, perio, pros, GREED, or a diplomate of the ICOI, or a diplomate of the ABOI ID, or a fellow of the American Academy of Implant Dentistry. It's just that all those, they have been assessed as to having some competencies in implant dentistry. If you're those, we do have a remote residency program for you, where if you own your own practice, you stay in your practice. You still work with EPAs, but you have a remote director who you report to, and so you never have to leave your practice. You stay there, you get it all, you do all the didactic work, you do all the EPAs, you get the same master's degree, and it's a 2-year program as well for them. Wow. So we have a handful of those in our program now.
Very cool.
Excellent.
Very cool. Well, Dr. Rutkowski, this has been an absolute pleasure. And I think both of us I speak for Storm when I say that we learned way more than we ever even expected to with this interview. We're already jazzed about learning about the residency, of course, but we got schooled on all kinds of pharmacology stuff, which has been an absolute pleasure. And these are things that we talk about all the time. So really, thank you so much for sparing your time. And I hope that the fans of our show will be reaching out to you about their interest in the program. And we hope to use you as a resource in the future as well for all of our burning questions about implantology, because you have an incredibly deep and broad knowledge.
And kudos to the two of you for what you're doing.
Thank you.
We're all brothers and sisters in implant dentistry.
You bet.
And we all have the same joys. We all have the same anxieties. And all of us, I truly believe, we really want what is best for our patients. And I truly believe that.
Yes,
and it's exemplified so clearly by the things that the two of you are doing. So thank you very much for inviting me. Thank you for being who you are and the work that you're doing. So hats off to you guys.
Likewise. Thank you.
Have a good evening. Bye.